This is a 58-year-old female patient who has heart failure with reduced ejection fraction, paroxysmal atrial fibrillation, and she is in sinus rhythm currently. Her QRS complex is 100 milliseconds. Her coronary angiogram is normal, and she is presenting with worsening shortness of breath that required admission twice in last 12 months. She also, at presentation, was complaining of orthopnea, PNDs, that developed over the last 2 weeks. Upon examination, there was systolic murmur on the apex, congested neck veins, and bilateral basal crepitations. This patient was admitted to the coronary care unit. IV diuretics were started. Patient improved, slightly improved. Then she was transferred to the general ward, and after that, she was discharged upon her guideline-directed medical therapy. However, she is still complaining of class 3 heart failure manifestations despite of these medications at these are her maximally tolerated doses. This is her echocardiogram. As you can appreciate, there is severe mitral regurgitation, depressed ventricular function. She has a diagnosis of dilated cardiomyopathy with no obvious etiology for the heart failure. This is more or less central. You can see it, okay. It looks central, and there is no suggestion of primary etiology for this severe mitral regurgitation. So what's next? If we revise the guidelines is proposing a stepwise approach for secondary mitral regurgitation. It starts with referral to the heart team, which is extremely essential in such states. Starting guideline-directed medical therapy, which should be maximally optimized. Offering the patient CRT if it is indicated. Then we ask ourselves if she has a life expectancy less than 1 year. If not, this patient doesn't have any significant comorbidities that limits her life expectancy. We ask ourselves if the patient is having other cardiac diseases that requires intervention. This is not the case here, so it goes with this arm of the algorithm. The second part of the algorithm, we should ask ourselves if this patient is appropriate for valve surgery. She is still symptomatic with severe secondary mitral regurgitation. If she became asymptomatic, this is for just close follow-up. This arm of the limb, if you can see, this arm, if she is asymptomatic. However, if she is symptomatic, we should ask ourselves if she is appropriate for valve surgery. If she is appropriate for valve surgery, we go directly to surgery. If not, we ask ourselves if she is more or less indicated for a clip or tear. If she is having end-stage LV or RV failure, we can consider in the presence, in your facility, left ventricle assisted device or palliative care. So what was done here? Okay, heart team meeting was done. Her Euro score was 2.87. So this is not that elevated, so she's not having a prohibitive risk. The question on the board was if we go for mitral valve replacement or clip.
30 seconds.
Okay. Or clip. According to guidelines, we have both options. However, the heart team discussion was for mitral valve replacement, which was done, and the patient came for follow-up. We went for metallic mitral valve replacement, and the patient went for follow-up, and she was improving. Our take-home messages: if the heart team is in secondary mitral competence is an essential part of the management. Surgical intervention is still an option for patients with accepted risk, and you should consider transcatheter mitral valve interventions.